Hello everyone and welcome back. My name is Dr. Ben Osevwe, DNP-PMHNP. Today, we are continuing our high-yield ANCC PMHNP exam review for my PMHNP students. In the last video, we covered the first 15 questions. Today, we are going through the last 15 questions from this review set. As always, we are going to read the full question, go through all the options, identify the correct answer, and explain the rationale in a way that helps you think like a PMHNP on exam day. Remember, the ANCC exam is not only asking, do you know the fact? It is asking, can you choose the safest, most appropriate, most therapeutic answer? So grab your notebook, stay focused, and let's get into it. Question 16. A patient has severe depression and has failed several adequate medication trials. Which testing may be considered to help guide medication selection? A. Pharmacogenetic testing. B. Routine brain MRI for all patients. C. EEG for antidepressant selection. D. Chest X-ray. The correct answer is A. Pharmacogenetic testing. Rationale. Pharmacogenetic testing may be considered when a patient has had inadequate response or significant side effects after multiple medication trials. It may help identify genetic variations that affect medication metabolism, such as CYP450 enzyme activity. This does not mean pharmacogenetic testing tells you the perfect medication. It is not magic. It is more like a clinical flashlight. It may help guide medication choices, but you still need clinical judgment. Routine brain MRI is not used for every patient with depression. EEG is not routinely used to select antidepressants. A chest X-ray does not help guide antidepressant selection. Exam Pearl. Multiple failed medication trials? Think about pharmacogenetic testing after confirming that the trials were truly adequate. Question 17. A young woman presents to the clinic 1 week after starting fluoxetine. She has fever, sweating, agitation, and abnormal neck movements described as rolling. She also smokes cigarettes. Which condition should the PMHNP be most concerned about? A. Serotonin syndrome. B. Hypothyroidism. C. Normal adjustment to fluoxetine. D. Seasonal allergies. The correct answer is A. Serotonin syndrome. Rationale. Fever, sweating, agitation, and abnormal neuromuscular findings after starting a serotonergic medication, such as fluoxetine, should raise concern for serotonin syndrome. Serotonin syndrome may include mental status changes, autonomic instability, sweating, fever, tremor, clonus, hyperreflexia, diarrhea, muscle rigidity, and agitation. This is not a normal adjustment to fluoxetine. Hypothyroidism usually presents with fatigue, cold intolerance, weight gain, constipation, and slowed thinking. Seasonal allergies do not explain fever, sweating, agitation, and neuromuscular symptoms. Smoking is important in psychopharmacology, especially with medications such as clozapine and olanzapine because smoking induces CYP1A2. But in this question, the urgent clue is fluoxetine plus fever, sweating, agitation, and abnormal movements. Exam Pearl, SSRI plus fever, sweating, agitation, and neuromuscular symptoms equals think serotonin syndrome. That is not a wait-and-see situation. Question 18. A 2-year-old child who previously used words now has language regression, poor social engagement, limited emotional reciprocity with parents, and tantrums. Which diagnosis is most likely? A. Autism spectrum disorder. B. Rett syndrome. C. Oppositional defiant disorder. D. Separation anxiety disorder. The correct answer is A. Autism spectrum disorder. Rationale. Autism spectrum disorder may present with deficits in social communication, poor emotional reciprocity, limited engagement with caregivers, restricted or repetitive behaviors, sensory issues, tantrums, and sometimes developmental regression. Rett syndrome can also involve regression, but the exam usually gives additional clues such as the child being female, loss of purposeful hand use, hand-wringing movements, gait abnormalities, and severe language impairment. Oppositional defiant disorder involves defiant, argumentative, or vindictive behavior. It does not explain language regression and poor social engagement. Separation anxiety disorder involves excessive fear about separation from attachment figures, not core social communication regression. Exam Pearl: toddler with regression plus poor social engagement should make you think autism spectrum disorder. But always watch for Rett syndrome clues like hand-wringing and loss of purposeful hand use. Question 19. A young girl had normal early development, but now has regression, loss of purposeful hand use, hand-wringing movements, poor coordination, and severe language impairment. Which diagnosis is most likely? A. Autism spectrum disorder. B. Rett syndrome. C. Conduct disorder. D. Selective mutism. The correct answer is B. Rett syndrome. Rationale. Rett syndrome is a neurodevelopmental disorder that typically affects girls and involves regression after a period of apparently normal development. Classic findings include loss of purposeful hand skills, stereotypic hand movements such as hand-wringing, impaired coordination, gait abnormalities, and severe language impairment. Autism spectrum disorder can involve regression and social communication deficits, but hand-wringing and loss of purposeful hand use are classic clues for Rett syndrome. Conduct disorder involves aggression, rule violation, or serious violation of others' rights. Selective mutism involves failure to speak in specific social situations. Exam Pearl: girl plus regression plus hand-wringing equals Rett syndrome. When the exam gives you hand-wringing, pay attention. Question 20. A patient with depression reports active suicidal ideation and difficulty regulating emotions. Which psychotherapy is especially useful for reducing self-harm and improving emotion regulation? A. Dialectical behavior therapy. B. Psychoanalysis. C. Aversion therapy. D. Light therapy only. The correct answer is A. Dialectical behavior therapy. Rationale. Dialectical behavior therapy, or DBT, is especially useful for patients with suicidal ideation, self-harm behaviors, emotional dysregulation, impulsivity, and borderline personality traits. DBT teaches mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. These are exactly the skills patients need when emotions become intense and unsafe behaviors start showing up. Psychoanalysis focuses more on unconscious conflicts and early experiences. Aversion therapy is not the best treatment for suicidal ideation and emotional dysregulation. Light therapy may help seasonal affective disorder, but it does not directly target self-harm and emotional dysregulation. Example: suicidality plus emotional dysregulation or self-harm equals DBT. But always remember, if there is active suicidal ideation, safety assessment comes first. Question 21. A teen presents with depressed mood, social withdrawal, weight loss, hypersomnia, and refusal to attend school. Which therapy is most directly focused on identifying and changing depressive thoughts and behaviors? A. Cognitive behavioral therapy. B. Structural family therapy. C. Psychoanalysis. D. Aversion therapy. The correct answer is A. Cognitive behavioral therapy. Rationale. Cognitive behavioral therapy, or CBT, is a first-line psychotherapy for depression in adolescents. CBT helps the patient identify negative thoughts, behavioral withdrawal, avoidance, and maladaptive patterns that maintain depression. This teen has depressed mood, social withdrawal, weight loss, hypersomnia, and school refusal. CBT can help address depressive thinking and gradually increase healthy behaviors. Structural family therapy may be helpful if family boundaries, roles, or conflict are the main focus. but CBT is more directly targeted to depressive symptoms. Psychoanalysis is not usually first line for adolescent depression. Aversion therapy is not appropriate here. Example: teen depression with withdrawal and school avoidance. CBT is usually a strong answer. Question 22. A teenager with depression refuses school, isolates in the bedroom, sleeps excessively, and has lost weight. The family reports frequent conflict and poor boundaries at home. Which therapy may be especially helpful if the primary focus is improving family structure and interaction patterns? A. Structural family therapy. B. Exposure and response prevention. C. Electroconvulsive therapy. D. Habit reversal training. The correct answer is A. Structural family therapy. Rationale. Structural family therapy focuses on family boundaries, hierarchy, roles, and interaction patterns. If the question emphasizes family conflict, poor boundaries, and family structure, structural family therapy may be the best answer. Exposure and response prevention is mainly used for obsessive-compulsive disorder. ECT may be considered for severe, treatment-resistant depression or depression with psychosis, catatonia, or high suicide risk, but it is not the best answer for family structure problems. Habit reversal training is commonly used for tic disorders and body-focused repetitive behaviors. Example: when the exam says family conflict, boundaries, hierarchy, and structure, think structural family therapy. Question 23. A patient with schizophrenia is taking risperidone 1 mg daily. Psychotic symptoms are controlled, but depressive symptoms remain significant. What is the most appropriate next step? A. Add an SSRI while continuing antipsychotic treatment. B. Stop risperidone immediately and start an SSRI alone. C. Increase risperidone only and ignore depressive symptoms. D. Stop all medications. The correct answer is A. Add an SSRI while continuing antipsychotic treatment. Rationale. If the patient's psychotic symptoms are controlled on risperidone but depressive symptoms remain significant, the PMHNP may consider treating the depressive symptoms with an antidepressant, such as an SSRI, while continuing antipsychotic treatment. Stopping risperidone immediately could increase the risk of psychotic relapse. Starting an SSRI alone would not protect against psychosis. Increasing risperidone may not address depressive symptoms and could increase side effects. Stopping all medications is unsafe. Example: if psychosis is controlled but depression remains, treat the depression without removing the medication that is controlling psychosis. Question 24. A patient with schizophrenia on risperidone reports ongoing hallucinations, paranoia, and disorganized thinking. The current dose is low and the patient is adherent. What should the PMHNP consider? A. Optimize or increase the antipsychotic dose as clinically appropriate. B. Stop the antipsychotic and start only an SSRI. C. Ignore the psychosis and focus only on sleep. D. Diagnose malingering immediately. The correct answer is A. Optimize or increase the antipsychotic dose as clinically appropriate. Rationale. If psychotic symptoms remain active and the patient is adherent to a low antipsychotic dose, the PMHNP should consider optimizing the antipsychotic dose before switching or adding unrelated medications. An SSRI alone will not treat primary psychotic symptoms. Ignoring ongoing hallucinations, paranoia, and disorganized thinking is unsafe. Malingering should not be assumed without careful assessment. Example: active psychosis on a low antipsychotic dose. Think optimize the antipsychotic. Question 25. A patient with schizophrenia refuses oral medication because they forget doses often, but says they are open to injections. Which option may improve adherence? A. Long-acting injectable antipsychotic. B. Abrupt discontinuation of antipsychotic therapy. C. St. John's wort. D. Benzodiazepine monotherapy. The correct answer is A. Long-acting injectable antipsychotic. Rationale. Long-acting injectable antipsychotics can improve adherence for patients who have difficulty taking daily oral medication and are willing to receive injections. The key phrase is open to injections. That means the patient is participating in shared decision-making. A long-acting injectable is not a punishment. It is a tool to support adherence and reduce relapse risk. Abrupt discontinuation increases relapse risk. St. John's wort does not treat schizophrenia and may interact with other medications. Benzodiazepine monotherapy does not treat core psychotic symptoms. Example: LA can be helpful for adherence, but the patient's agreement matters unless there is a legal or emergency exception. Question 26. A patient taking fluoxetine presents with fever, diarrhea, sweating, tremor, hyperreflexia, and confusion. Which action is most appropriate? A. Stop serotonergic agents and arrange urgent medical evaluation. B. Increase the fluoxetine dose. C. Tell the patient this is expected and will pass. D. Add St. John's wort. The correct answer is A. Stop serotonergic agents and arrange urgent medical evaluation. Rationale: fever, diarrhea, sweating, tremor, hyperreflexia, and confusion are concerning for serotonin syndrome. Serotonin syndrome can be life-threatening and requires stopping serotonergic medications, supportive care, and urgent medical evaluation depending on severity. Increasing fluoxetine would worsen serotonin toxicity. Telling the patient it is expected and will pass is unsafe. Adding St. John's wort can increase serotonergic activity and make the situation worse. Example: serotonin syndrome is not a just monitor at home situation. Fever plus autonomic symptoms plus neuromuscular findings is a red flag. Question 27. Which medication combination increases the risk of serotonin syndrome? A. Fluoxetine and St. John's wort. B. Risperidone and calcium carbonate. C. Bupropion and vitamin D. D. Melatonin and ibuprofen. The correct answer is A. Fluoxetine and St. John's wort. Rationale: St. John's wort has serotonergic properties and can interact with antidepressants such as SSRIs. Combining St. John's wort with fluoxetine can increase the risk of serotonin syndrome. Risperidone and calcium carbonate do not create the same serotonin toxicity concern. Bupropion and vitamin D are not a classic serotonin syndrome combination. Melatonin and ibuprofen do not significantly increase serotonin toxicity risk. Example: always ask about supplements. St. John's wort is a major interaction trap on exams. Question 28. A patient asks whether St. John's wort is a safer alternative to antidepressants during pregnancy. What is the best response? A. Yes, it is always safer because it is herbal. B. No herbal products can ever be used by anyone. C. We should discuss safety concerns, limited pregnancy data, possible drug interactions, and evidence-based alternatives like therapy. D. Take it with fluoxetine for better results. The correct answer is C. We should discuss safety concerns, limited pregnancy data, possible drug interactions, and evidence-based alternatives like therapy. Rationale: the PMHNP should provide balanced education. St. John's wort is not automatically safe in pregnancy and may interact with medications. Evidence-based non-pharmacologic options, such as psychotherapy, should be discussed. Option A is incorrect because herbal does not always mean safe. Option B is too absolute. Option D is unsafe because combining St. John's wort with fluoxetine may increase the risk of serotonin syndrome. Example: herbal does not mean harmless. St. John's wort loves to interact with medications. Question 29. A patient with depression has failed multiple antidepressant trials. Before labeling the patient as treatment resistant, what should the PMHNP assess? A. Medication adherence, adequate dose and duration, diagnosis, comorbidities, substance use, and bipolar disorder. B. Only the patient's favorite color. C. Whether the patient has watched enough television. D. Whether the patient should stop all medications permanently. The correct answer is A. Medication adherence, adequate dose and duration, diagnosis, comorbidities, substance use, and bipolar disorder. Rationale. Before diagnosing treatment-resistant depression, the PMHNP should confirm that medication trials were adequate in dose and duration and that the patient actually took the medication. The clinician should also reassess the diagnosis and screen for bipolar disorder, substance use, medical contributors, trauma, medication interactions, sleep disorders, and psychosocial stressors. Sometimes what looks like treatment-resistant depression may actually be non-adherence, inadequate dosing, untreated substance use, misdiagnosed bipolar depression, or a medical condition. Option B and option C are not clinically relevant. Option D is unsafe. Exam Pearl. Before calling it treatment resistance, make sure it was truly treated. Question 30. A patient with depression and active suicidal ideation presents to the clinic. What is the PMHNP's priority? A. Assess suicide plan, intent, access to means, protective factors, and level of care needed. B. Begin CBT homework immediately. C. Schedule follow-up in 6 months. D. Avoid asking about suicide because it may worsen symptoms. The correct answer is A. Assess suicide plan, intent, access to means, protective factors, and level of care needed. Rationale. Safety is always the priority. The PMHNP must assess suicidal ideation, plan, intent, access to means, prior attempts, protective factors, support systems, substance use, impulsivity, and determine the appropriate level of care. CBT may be helpful later, but immediate suicide risk assessment comes first. Scheduling follow-up in 6 months is unsafe. Avoiding suicide questions is incorrect. Asking about suicide does not cause suicide. It helps identify risk and create a safety plan. Exam Pearl. Anytime you see suicidal ideation, safety assessment comes first. On the ANCC exam, safety is the boss. Quick recap for today. Multiple failed depression medication trials. Consider pharmacogenetic testing after confirming adequate trials. Fluoxetine plus fever, sweating, agitation, and abnormal movements. Think serotonin syndrome. Toddler with regression and poor social engagement. Think autism spectrum disorder. Girl with regression, loss of purposeful hand use, and hand-wringing. Think Rett syndrome. Suicidality plus emotional dysregulation or self-harm. DBT is especially useful, but safety comes first. Teen depression with withdrawal and school refusal. CBT is commonly appropriate. Family conflict, poor boundaries, hierarchy problems, structural family therapy. Schizophrenia controlled, but depression persists. Continue antipsychotic and consider adding an SSRI. Active psychosis on a low antipsychotic dose. Optimize or increase the antipsychotic as clinically appropriate. Schizophrenia patient forgets oral medication and agrees to injections. Consider a long-acting injectable antipsychotic. Serotonin syndrome symptoms. Stop serotonergic agents and arrange urgent medical evaluation. Fluoxetine plus St. John's wort, increased serotonin syndrome risk. St. John's wort in pregnancy. Discuss limited data, safety concerns, interactions, and therapy options. Before calling depression treatment resistant, assess adherence, dose, duration, diagnosis, comorbidities, substance use, and bipolar disorder. Depression with active suicidal ideation. Assess plan, intent, means, protective factors, and level of care. That is it for today's ANCC PMHNP review. Remember, the exam wants you to think clinically. Ask yourself, what is safest? What is the priority? What is the most therapeutic response? What diagnosis or side effect can I not afford to miss? Thank you for watching. Again, my name is Dr. Ben Osevwe, DNP-PMHNP. For support, you can text 83299165516. Please subscribe to our YouTube channel for more educational videos and join our mentorship family today at academy.rotationmatchnetwork.com.